And so with that, let's jump from the frying pan into the fire and let's talk about persistent pain. Pain that's, going on longer than somebody would expect. I know every patient that walks in my door who's had a total knee replacement, as you kind of mentioned, they had it to resolve a pain issue. And now 3 months, 6 months, 12 months down the road, they have a different pain issue. They've traded one pain for another. And they're frustrated and they're not sleeping. And, I empathize the best that I can with them. But I do find that most of the time, the hardware is intact, the bone is intact, structurally, everything is sound. And, we're fighting ghosts a little bit here in the sense that it's not something that we can grab and control and manipulate and touch and measure and do these things. So in your experience, in your clinical history, I know that there are patients who are so fearful that once the surgeon's job is done, they're done, and the surgeon doesn't want anything to do with them. And it's been 3 months and now they've got nobody really there in their corner anymore. And some will seek pain management, some will go back to the primary care. But what are some of the options? What have you seen for those individuals who just continue to deal with this persistent pain?
If you allow me, I just want to sort of take it a little step back. Yeah. So, we talked about doing the surgery for the right reason. So that's the reason why, number one, before you even have the surgery, you want to make sure these folks have advanced disease, their pain patterns make sense. It can't just be normal x-rays with, I have pain in my knee, right? And so I just want to make sure that all my patients, when they went to surgery, they had it for the right reason, because we have those conversations way, way less to almost zero, because I had the right operation in my mind. Because knee pain could be from the knee pain could be from the back, knee pain could be from the hip. So I published a paper that folks essentially had knee pain, absolutely no complaints in their hip, and they went and saw doctors. They had cleanup surgery, they had replacement, they had revision surgery, and all of a sudden, some revision or second opinion or third opinion doctor felt their hip, and their hip was completely locked and stiff, and got an x-ray, sure enough, bone on bone. And those folks were still very hard to convince that, hey, it was never your knee, it was your hip. No, I'm not sure what you're talking about, but it's called referred pain. So it's issues somewhere, and the nerve fibers sort of travel down to the knee. And so those are the nerves that are activated. So you feel it as a knee pain, but it's actually your hip. And they had a hip replacement and their knee pain went away. So number one, you want to make sure of that. So, that knee x-ray better show the disease. Otherwise it can't show mild disease. That's the other reason that it's very frustrating to have this conversation sometimes with the patient, or they're frustrated with me to have this conversation, is that, well, I have knee pain, my MRI shows meniscal tear, I have pain, doctor. And even though their meniscal debridement was done 2-3 times, they want their knee replacement. Well, I can't do a knee replacement because the meniscus is torn, right? So it's again, another operation for the wrong reasons, because the rest of the cartilage is okay. So you want to do it for the right reason. So now afterwards, when you do have the surgery, and this was for the right reasons, you want to really get a good history and physical. So this patient shouldn't be ignored. This patient should not be pushed aside. These are the patients that you close the door, you sit down, and you truly talk to them, right? You want to get their history. What was your pain before surgery? What is your pain now? Is it the same pain? If it's the same pain, then something's wrong. Maybe we did the wrong operation. Maybe now we should be looking somewhere else. Is it the hip? Is it the spine, or something else going on? If they say, no, that pain is completely gone, now it's something different, then you can sort of dive in a little bit deeper into the knee itself. So physical history and physical is very, very important in the beginning to kind of tease those things out. Is your pain, because things can look great on x-ray, right? You saw yourself actually look great, the knee model looks fine, the bone looks okay, but some things you can tease out of the patient make sense. So pain with climbing stairs, going downhill, recurrent effusion, swelling of the knee. Okay, well, and then you sort of look at the x-rays and you say, okay, well, this particular prosthesis, your surgeon left your PCL intact, because you can leave some of the ligaments and you can take most of the ligaments. And so if they leave some of the ligaments with the first surgery, those ligaments now can either stretch out, those ligaments now can tear, and it causes this instability in their knee that causes this swelling. So a lot of times those folks need a revision to either a bigger plastic or a complete revision to give more stability to their knee. And then the other sort of dreaded thing every surgeon should keep in mind is infection, right? I've seen many times a year and a half out, surgeons telling them, I'm done with you, as you said, your x-rays look fine, go see your physical therapist, you're not doing your physical therapist, and then continue with that. And then they come to me and they still look like that, they still have the skin changes, they still have the swelling. You want to make sure you rule out an infection, so you can either check simple labs by blood, or you can stick a needle in their knee. And it's always a good idea to sort of test the fluid to make sure that's not infected. You do not want to miss that. It's a big deal. If you don't get to the infection sooner, then they can spread to bone and it can be a harder operation to treat with. Then you have the scarring, right? We sort of heal with scarring. And so what I tell my folks is this: my knee replacement was literally removing about 1 centimeter of bone. Even though it's a big surgery, it's a lot of moving pieces and a lot of parts we have to cut and do. But ultimately, I break it down by saying I just removed about 1 centimeter of bone. It's still your top bone and bottom bone. It's still the covering of the knee. It's still the ligaments on the side. It's still the kneecap with the quad tendon and the patella tendon in the front. It's still the muscles around it. It's still the bursa around the pads. So we have to sort of check all these things. Is it weakness? Is it the ligaments being sprained? You can still have a knee sprain, right? Because you're now walking, your strength is not where it needs to be. So every time you walk, you put a little strain to your ligaments. Your ligaments are constantly being worked in a natural way or not a mechanical correct way. Is it tendinitis, right? Could you have tendinitis? Could you have bursitis, inflammation of the bursa? Could you have inflammation of the tendons around the muscles? So ultimately, though, right, when we sort of say, hey, I've done all these, the physical therapist says, I've exhausted everything you can. I've ruled out the bad stuff, right? There's no infection going on. Mechanically feels okay. It's not unstable. It could still happen, right? It could still have a scarring to them. It's painful. It doesn't feel good. And they are not happy with it. This is where that dissatisfaction comes from knee replacement. But the key is to just never blow off that patient. The key is to always talk to the patient. Every surgeon, either they haven't operated long enough or they're just hiding. Every surgeon has that patient in their clinic who is just not happy. Could it be the stiffness? Could it be the fact that their knee used to move to 135 degrees or 140 degrees, even though it was bone on bone? People need to understand that you lose motion with arthritis, but you also lose motion with knee replacement because scarring sets in. That's how we heal. So you're not going to have this amazing 145, but you can get to 130, 135. I think it's a great result. I think people are doing most things they need to do: climb, hike, bike, elliptical. Some people play tennis still with that range of motion. So, you always want to talk to these patients. Your door should always be open to these patients. You should always keep hearing it. And then I always, once or twice, I say, look, I can only see what I can only see, right? It's always a good idea to get a second opinion. I even offer that to my own patients. Say, hey, look, it would not offend me. If someone else wants to look at you, I'm totally fine. I'm happy to give you great recommendations of my own colleagues who do this, who do what I do, which are revisions, and we're all fellowship trained joint surgeons. And I'm able to find something wrong with them. It's always a good idea just to get another set of eyes to look at it. Because a lot of times you'll see that folks just want reassurance. You'll find that if something's not right and you say, hey, look, we did everything. You're like, oh, okay. And then so they are okay with it. They just wanted to make sure that nothing bad was going on. Everything's okay. Everything's performing okay. You're there for them. Your door is open. As you know, I give my cell phone number to my patients. So that alone, even though they may not be 100% satisfied, they're still very much happy with me, very much happy with the care, very much happy with the attention they got, because that's all they want. They want to be heard. So you just have to be there for them, because it can be difficult sometimes to just, say, look, I'm sorry, there's nothing I can do, but I'm happy to see you again. You can come back in another 3 months, another 6 months. We can get on an x-ray, because you never know, maybe something shows up at those x-rays, or sort of you have to explain it that way. I'm always going to be there for you. This is a long journey. We'll walk it together. And you'll find that most folks are okay with that. As long as you did your due diligence, you're not missing any of the bad stuff. They're happy with it, and sort of they change their mind, and all of a sudden they're okay. Maybe this knee isn't so bad, and I'm happy with my range of motion. I'm happy that it's straight. I'm happy that I don't have the pain of the bone on bone, and so they kind of put things in perspective a little bit. And then again, it goes back to setting realistic expectation too, which I do a lot. I sit down before surgery and I explain the potential complications. I explain the potential dysfunctions or less than perfect function of your knee and what that means, and what's a knee replacement like. It's all about that. And that's the reason why there are such dissatisfactions. I don't think surgeons spend a lot of time with their patients before surgery. Sometimes they see a PA, then it's booked for surgery right after that. And after that, they don't see the surgeon anymore. They just see the physical physician assistant or a nurse practitioner. So I always see my patient. I think it's important because they want to feel like someone's always paying attention to what's going on.